Wow. Mm. How you doing? How you doing? Oh, let me, How you doing? Oh, let me, How you doing, Dr. Sbeih?
Hello, John. How are you?
Very good. The sound is fine. How you doing, Dr. Sbeih?
Hello, John. How are you?
Oh, I see. That's the sound is fine. That's where I'm getting the sound from. From another computer. I get confused sometimes. So how you been? You been traveling at all or staying home?
No, staying home busy. Staying home busy, operating and teaching, and
You staying busy at the hospital?
yeah, of course. This is the season for the cases coming from outside the Arab country. They choose the summertime to come to Jordan for treatment.
How's your daughter doing?
Yeah.
Good. Yeah, your daughter's welcome to present if she wants.
Hello? Sorry,
Yeah,
John?
can you hear me?
Yes,
Okay. Yeah, your daughter is welcome to present if she wants.
sure. Now she is spending time with my rest of my family, my wife and other kids in Turkey. They went for shopping. So she is there for a
okay.
week.
Oh,
But
she's
then she comes
training.
back-
She's not training now. She's in Turkey,
No,
you
she-
think?
No, she finished her training now. She's fully established in neurosurgery.
Oh, okay.
Yeah.
So she's a practicing neurosurgeon now.
Absolutely, yes.
Great. In Jordan?
In Jordan, yes.
And oh, okay. The same hospital.
Yes.
Oh,
Same-
that's nice.
The same clinic. My name and her name on the door.
Okay.
But she went for so many courses around the world. She went to Austria, to India, to Germany, to England, trying to improve her expertise.
You know, did you say she's doing ultrasound?
She's doing endoscopy.
Oh, okay, endoscopy. Which you probably suggested that, right?
Yeah, absolutely. Because I think it's the future of neurosurgery.
You're right.
Endoscopy, yeah. Endoscopy is the future of every surgery around the world.
Does she use the endoscope? I mean, does she use the screen, like the exoscope screen,
No,
or
no.
does she use a microscope?
Endoscope and microscope, both.
And okay, combination of endoscope and microscope.
Yep.
Okay. Has she tried the screen also with the exoscope and the endoscope?
Not yet. Maybe this is the next step.
Okay. I think you need equipment for that, right? Special equipment.
Yeah.
Hello, Solomon? Yeah, I guess he didn't want to be addressed.
So is it hot in Miami?
Yes, I'm in Miami Beach.
Hmm.
And I haven't traveled at all for a long time,
I know.
even before the COVID. But that's okay. I don't mind. I think as they get older, I don't want to travel as much.
Absolutely. The hassle of travel is too much.
Yeah, it's straining. It's very strange. And I'm used to working near my computer. I just go crazy if I'm away from my computer.
Sure.
Now, did your daughter like training in England? That's old
Uh,
traditional neurosurgery, right?
Yeah, she, as I said, she went everywhere, but the best place she loved was India.
She liked India?
Yeah,
Really?
absolutely. Yeah.
Oh, okay. Which is she thinking of going there for a while or?
Well, she's been offered so many positions from my colleagues, Kiki Torell and all the others, so she may go. Yes,
Will she go there to work or to train? To train in different hospitals?
to work.
To work, okay.
Yeah.
Because you guys travel around a lot when you're training.
True.
You probably did, right? You probably went to different places.
Every country in the world, almost.
Really? Yeah, so where have you been for your fellowships and training?
England,
India?
London, England.
England. Oh, okay.
London, yes. And I went to Germany, States, everywhere.
Germany. Did you
Yeah.
come to the States?
Yes,
Which part?
every part. New York till Miami, San
Oh, you were at
San
Miami
Francisco.
with
Yeah,
Jacques?
Los Angeles, Chicago, everywhere.
Wow, we've been all these places. Wow.
Absolutely.
Well, I guess that's probably what I suggested for a young neurosurgeon is to travel and learn.
Yeah. I visited Roten in his cadaveric lab in Gainesville, Florida.
Or the laboratory, training laboratory.
Yeah.
Yeah, I did an interview. It's mostly robotics, right? Training.
No,
It's all
It's-
different types of training.
it is cadaveric lab where you just
Oh,
dissect.
cadaver. Oh, you
Yeah.
mean, I'm sorry. The famous guy.
The famous Roten. Yes.
Gainesville. That's right.
Gainesville. Yeah, true.
That's right. You were there for like a couple of months, right?
Absolutely. Yeah. Several times.
Several times. Wow. Yeah.
He became like a father figure for me.
Oh, really?
Yeah. We had this kind of close relationship.
Yeah. Well, yeah. He seemed to be dead. He seemed to be like you, huh?
Absolutely. Yes.
Very
He's
simple. Very simple. Neurosurgery was his life. Period.
modest and honest.
Yeah. I treat it as an art, huh?
Yeah.
He had a lot of, he used a lot of references besides neurosurgery during his lectures, right?
True.
Like a well-rounded, educated man.
Yeah.
He drew in references from other fields of study.
He would go and teach in Japan, and 3 days later he would be teaching in Ecuador or something.
Well, that's great. Okay, we start in a few minutes. I just got to do
Yeah,
one more
sure.
thing, okay?
Sure.
Okay, starting shortly. Hey, Dr. Sbeih, are you ready? Hello, Dr. Sbeih. Hello, Dr. Sbeih, are you there? Can you guys hear me? Can anybody hear me? Oh, yes, you can. Okay, you can hear me. Thank you. Yeah, if anybody in the panel wants to make a comment or ask a question, you can just type it in. You don't have to come in. You're welcome to come in to do the questions face to face if you want, or you can just put in the text. Hi, Dr. Sbeih. Hi, Dr. Sbeih.
Hello.
Are you ready to go?
Yeah, I'm ready.
Okay, let's go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have another Jordanian neurosurgery grand round with Ibrahim Sbeih, who has been all over the world. I was just chatting with him before the show. He's done fellowships everywhere, the States, England, etc. Anyways, we welcome him, and it's his show. Hello, Dr. Sbeih, it's all yours.
Thank you, John. Good evening, everybody here in the auditorium and everybody on the internet. We are transmitting live from the Farah Medical Campus here in Amman, Jordan. I thought of this to say that I am evolution of those monkeys. This is the black iris symbol of Jordan. And this is the jewel of the crown, Petra of Jordan. So we'll be talking today about third ventricular Langerhans histiocytosis. Can you hear me?
Voice.
وين مصاب? So we'll be talking about Langerhans cell histiocytosis. we'll touch on the clinical, radiological, operative, pathological aspects of the disease. So in the middle of this slide is this man, Langerhans. And this is his famous slide long time ago. So I'll start with the case presentations actually, and then we will go on to discuss the topic itself. This is a 39-year-old male patient from Iraq, Kurdistan. This is back in 2005, which is almost a dog's years. He came with a history of 1 year of impotence, polydipsia, polyuria, and fatigability, and 1 month later of headaches and blurring of vision. So this was his images. You can see this lesion in the third ventricle. And this is the lesion sitting on top of the pituitary. Just don't see the stalk. This site is a preferable site for these cases. And the literature does not have many cases. So for me to have 3 cases of third ventricular Langerhans is too much. So this is the lesion sitting on the cella, occupying the infundibulum, and then going to the third ventricle. He was found to have multiple fractures, and that is relation to his disease. Langerhans could be one system affecting, say, the brain, or multiple systems affecting the brain, the lung, and the bones. So this patient had multiple fractures due to Langerhans. We got his pulmonary consultations, and he showed so many changes in his lungs. And this is the operative view, still pictures. We are going through right craniotomy. Here is the right optic nerve, optic chiasm, left optic nerve, and this is the carotid artery. So you can see the tumor here, and you can see it here in the corridor between the optic and the carotid. Again, close picture, internal carotid, right optic nerve and chiasm. You can see the tumor here, and you can see it here. So we start removing the tumor from here and from here. And we created a space between the right optic nerve and chiasm and the carotid artery, the so-called optico-carotid triangle. And we use the ultrasonic aspirator to excise the tumor. You can see the tumor there. This is very unusual site for Langerhans histiocytosis. So this is the preoperative, and this is the postoperative. So a tumor was removed from his hypothalamus, and the tumor was removed from the bone that I showed you with the fracture. So the bone tumor and the hypothalamic tumor were all eosinophilic granuloma, meaning that this is the multiple system Langerhans cell histiocytosis, which has a bad prognosis. And these are the slides to prove it. Another case with this tumor in the area of the hypothalamus. Again, we went in and removed it. So this is just a case of presented many presentation for those cases. This is post-op. The main presentation of today is this young Jordanian female, 16-year-old Jordanian, and this is a recent admission, July 2023. She complained of 6 months of headaches, vomiting, blurred vision, dizziness, lethargy, and oversleep, and 3 months of polyuria, polydipsia, and secondary amenorrhea for the last 3 months. She was admitted to sent elsewhere because I don't want to disclose the name of the hospital. And this is the CT showing hydrocephalus, and you can see that there is a lesion there within the third and the thalamus. So these are the CTs of this patient. So what did they do? They put a shunt. I always keep saying that shunt is a disease of the Arab world because we use it for anything and everything. If you remove this tumor, you don't need a shunt. So as a first step to put a shunt, in a girl, 16-year-old. This is a crime against humanity. So a baby shunt was inserted, and she was admitted to our hospital upon the request of her family. Glasgow Coma scale 14/15. And you can see here, her right arm has some pronation drift, meaning early sign of weakness. So she has right-sided weakness of 4+ on the right side. Facial nerve is okay, eye movements are okay. We did all the tests, hematology, coagulation tests. TSR was within normal. And again, these are the CTs. And we did MRI, and you can see before contrast and after contrast. So there is abnormal contrast here, which is so funny. These are different sequences of the lesion with some lack of penetration in the ADC, the coronal. Again, this is very unusual kind of contrast enhancement. The lesion has got bigger by the time she got into the hospital. And here you can see the pituitary, but you don't see the stalk, you don't see the hypothalamus. So this is the lesion. And when you look at this, you get petrified. The man who done the shunt has no idea where to put the shunt. So not only that, a VP shunt is a disease of the Arab world, and the way of doing it is wrong. You can't put it transverse like this. You would go into major areas and you may damage the patient. In fact, she had some damage due to abnormal tract of the ventriculoperitoneal shunt. Shunt should go into the occipital horn, to the atrium, because this is the largest size of the ventricle. But here, we give the shunt to be done by the most junior staff, as if shunt is nothing. It's really terrifying. So, the differential diagnosis of this lesion, as we have seen it, what could that be? Again, last time we discussed that our radiologists do not put a list of differential diagnoses. They just describe, which is totally wrong. I am not waiting for you to tell me there is a lesion in the third ventricle. I want you to discuss with me in writing that this could be meningioma, this could be craniopharyngioma, why it cannot be a meningioma, why it cannot be a craniopharyngioma. But to say there is a lesion in the third ventricle, this is, to me, is nothing. So let's see the wide differential diagnosis, and I choose to use the cases that I have done. So these are my cases with the proven histology. This is oligodendroglioma. This is pilocytic astrocytoma, grade 2 astrocytoma, pituitary adenoma going into the third ventricle, aneurysm of the carotid artery going into the third ventricle. This is the case of, as I said, the astrocytoma. This is before surgery and after surgery. So these are documented cases with the proven histology. Choroid plexus papilloma, colloid cyst, oligodendroglioma, arachnoid cyst, craniopharyngioma. And this particular lady came to me from Libya. She was pregnant 8 months and she had almost loss of vision. So what we did is to deliver her by cesarean section and then went in and removed the tumor completely. Again, craniopharyngioma is treated badly in the Arab world. Germinoma, metastasis, sarcoidosis, histiocytic sarcoma in this Syrian girl, hamartoma, epidermoid. So the pathology is so wide. As a radiologist, you should tell me this cannot be epidermoid. This should be metastasis. This should not be sarcoidosis and so on. Teratoma in this patient from Bahrain, histiocytosis, optic nerve glioma from this Palestinian boy, a granuloma, lymphoma, we always forget about it, and subependymal giant cell astrocytoma. So all these are true cases, not imaginary cases. And this is very interesting case of hamartoma of the hypothalamus. This is a 1-year-old boy presenting with huge genitalia as if he was an adult. And that's because of the hamartoma. So we did surgery for him, partial resection, and we treated him with chemotherapy. Again, Langerhans cell histiocytosis, they love the hypothalamic pituitary axis, epidermoid, in this case of mine. So because of the location of the lesion and because of the manifestations, we asked Dr. Mohammed Jum'a, our consultant endocrinologist, to see her. Mohammed, would you come over here?
Welcome all colleagues. Thank you, Dr. Ibrahim, for inviting me for this interesting presentation. I had the opportunity to see this patient, youngster female. The main presentation actually it was headache, blurred vision, and amenorrhea. It was secondary amenorrhea, but there no real polyuria, polydipsia. There is no evidence of DI, which is a classical usually in cases of Langerhans histiocytosis. But Macan and the Marida, there is no evidence of DI. The only evidence was secondary amenorrhea, and I wrote in my consult it most likely it is hypothalamic amenorrhea because LH and FSH were within normal range, just low estradiol. And the rest of pituitary hormone, all of them intact, and I did not give her any medication. And from the beginning, my impression, it was written that it is craniopharyngioma, but from the beginning, it is not craniopharyngioma because the main manifestation of craniopharyngioma in such age usually short stature and diabetes insipidus, usually the first manifestation in child. But all of them, they absent, hand growth and the aqueous, the body weight, the normal, just headache and weight will height, normal chemistry, she can go, I wrote that she can go for surgery and under GA with the steroid coverage. Later on after surgery, I wrote that polycystic ovary should be excluded because of secondary amenorrhea.
So these are the pituitary function tests. We asked our
back to the pituitary function. If you look why I suspected the
ovarian
polycystic ovary, the ratio between LH and FSH, it is more than 2, which is highly suspicious to be polycystic ovary. And estradiol, it was low. Prolactin, normal. The rest of pituitary hormone was not.
We asked our cardiologist to see her because this is routine. Any patient going for anesthesia for long hours must be assessed completely. Dr. Tokan declared fit. We asked Dr. Ibrahim Saidat, are you here, Ibrahim? Please. She had blaring of vision, she had a third ventricular lesion, she had hydrocephalus, so that must have affected her vision.
Good evening, everybody. So I had the pleasure to see this interesting patient. Although she has blurred vision, but we measure vision, and sometimes we measure what we can measure. We measure visual acuity, we measure color vision. Sometimes we don't measure contrast sensitivity. We don't have a special device for that. So that's what patients mean by blaring of vision. They have good vision. They are able to see 6/6 but their vision is affected. So this patient, when we saw her, her vision was good. There was no apparent pupillary defect. The main problem with her exam was right homonymous hemianopia. So this is what we call right homonymous hemianopia, indicating a retrochiasmal lesion on the left side. So that's what we found with it. The OCT was almost okay. It is not affected yet. The retinal nerve fiber layer around both optic discs is okay till now.
So you can see that medicine is the cooperation between different specialties. We asked Dr. Raed Nofel to see her because she has a brain lesion. Raed, are you here? Can you please come over? You did EEG and it was abnormal, yes?
Thank you, Dr. Ibrahim. It was my pleasure to see this patient with here. We did, I consulted her, I did the EEG for her. There was abnormal intermittent focal slowing in the left temporal area, mainly in left temporal area, which indicates it's potentially epileptogenic. So we have to cover her with ethylene anti-epileptic for a few months after surgery and few days before that surgery. And she was at that time stable, and after surgery she didn't complain from any complication for this intermittent periodic wear. Thank you.
Okay. And we consulted with Dr. Lai Hamdan, the chairman of the anesthesia department. Is Lai here? No. Okay. So it is official consultation from every person in the team. We wrote this elaborate consent form, which I keep saying that we in Jordan, in the Arab world, we do not write proper consent form. What we write is rubbish. It does not stand in court. It does not stand in a common sense. The patient and the family, they have the right to know everything about the case. What do you expect? What are the complications, the percentages, and so on and so forth. So this is our elaborate consent form in every single case. It is tailored according to that particular case. أنا في المستشفيات عندنا أطباء المستشفى ينفوضهم بإجراء اللازم, which is nonsense. So we will go to the third ventricle. Third ventricle is the most difficult to expose and remove. Anatomy of the third ventricle is really difficult. So this is the shape of the third ventricle. This is the anterior horn, the body, the trigone, occipital horn, temporal horn of the lateral ventricle. And here in the middle is the third ventricle. Here is the thalamus, and here is the hypothalamus. So we're interested in this, the hypothalamus. It is only 4 grams in weight, but it controls your very existence. Everything in your body, this 4 grams control. Metabolism, eating, drinking, sexology, everything. So this is the third ventricle. And from the third, we have the aqueduct of Sylvius, goes into the fourth ventricle. If you add here the caudate nucleus and the thalamus, that's what you will see laterally on the third ventricle, on the third. And then you add the brainstem. So again, that's what you get. Add the cerebellum, you get a very complex anatomy. So, sagittal section, this is the thalamus. This is called interthalamic adhesion, and there is this sulcus between the thalamus and the hypothalamus. Hypothalamus is this elongated thing. This is very small, 4 grams in nature. It has anterior wall, has a roof, has a posterior wall, has a floor, and it has anterior wall. And if you look at these nuclei that controls your very existence and everything you do, they are arranged in a magnificent way. If you don't believe in God, you should when you see this. You see these nuclei arranged from front to the back, from medial to lateral, in a very, very unusual way. Every nucleus is responsible for something. So here you are, 4 grams full of nuclei. So if you want to go there, and a 16-year-old girl, you have to be careful. You don't want to damage her. And you will damage her if you don't have the knowledge of anatomy. So putting a shunt was stupid. So the roof, which is the body of the fornix, the floor, which is the mammillary bodies and the rest, anterior wall is the lamina terminalis, posterior wall is the splenium and pineal, and this is the lateral wall, thalamus and hypothalamus. So roof made of the fornix. Here is the anterior commissure, here is the anterior wall, and this is called lamina terminalis. This is the posterior wall made of vein of Galen and the pineal gland, and the floor you are sitting on the midbrain and then sitting on the hypothalamus. The roof of the third ventricle, if you open the fornix, you split it and open it, you will see two internal cerebral veins running from anterior to posterior, and there is the tilla choroidi. If you open it, you will be in the cavity of the third ventricle. If you look at the floor from below, these are the mammillary bodies, and this is tuber cinerum as you see it. If you look at the floor from above, this is the optic chiasm, and then you go from anterior to posterior to reach to the aqueduct of Sbeih. And this is very useful when you are doing endoscopy. The lateral wall of the third ventricle, the thalamus, and then the hypothalamus, and there is the sulcus between thalamus and hypothalamus. So these are the major nuclei here in the hypothalamus, and the nuclei are arranged. So if this is the midline, they are arranged near the midline, medial and then lateral, and from anterior to posterior, anterior, middle, and posterior. معجزة الخلق. If you look at here the third ventricle, you can see we have paraventricular, then we have the medial segments, and then the lateral segments, and the optic nerves are here. So these 4 grams control everything. Your weight, your height, your eating, everything. Again, third ventricle, paraventricular nuclei, لونهم أزرق, blue, and then the medial nuclei, and then the lateral nuclei. So if you have a tumor here, you better know what's exactly there so that you will not damage. Posterior wall made of the splenium and the pineal gland, and the anterior wall is the lamina terminalis. It's a glial tissue starting from the anterior commissure until it reaches to the optic chiasm. So this is the lamina terminalis, anterior wall of the third ventricle, and this is the hypothalamus. This paper by a friend of mine from Italy said that lamina terminalis is rhomboid in shape, like this. And this lamina terminalis has different shapes. So it can be straight, it can be more straight, it can be bulging in, it can be bulging out. All these abnormalities of the lamina terminalis must be understood. So I use the lamina terminalis approach to reach to this lesion. So I'll take you through the steps of the surgery by showing you some still pictures, and then we'll show you the video. I published this a long time ago, the lamina terminalis approach for third ventricular craniopharyngiomas and others, in 2012. And lamina terminalis approach is a standard approach of mine. So this is the skin incision, anterior, middle, or posterior. This is the pericranium that you can use for reconstruction, and this is the bone flap that you open. And then we cut the most anterior part of the superior-sagittal sinus. As here, we cut the forks. And then we preserve the olfactory tracts. And then you can see olfactory tracts being preserved. And then right optic nerve, left optic nerve, chiasm, optic tract, optic tract. Nerve, nerve, right and left, chiasm, and behind the chiasm is the lamina terminalis. Here you can see the A1 of the anterior cerebral artery, A1 of the anterior cerebral artery, here ACOM, and then you have the A2s. So this is the picture you would see. And this is a still picture from my surgery. Right optic nerve, left optic nerve, chiasm. This is A1, here is the carotid. A1, coming to become A2, A1 coming to become A2, and this is fenestrated ACOM. So you want to go in here in the lamina terminalis. So this is the picture from this little girl. Nerve chiasm is distorted. We open the lamina terminalis. And then we go into the third ventricle. The tumor is apparent now. We start removing it. Again, you can see the nerves, the chiasm, the tracts, and you can see internal carotid artery going into middle cerebral artery here and anterior cerebral artery here. So going deeper into the third ventricle, we start removing the tumor. This is T standing for tumor. T standing for a tumor. The cavity of the third. I'm aware that I should not damage the hypothalamus. This is a young girl of 16. Using the ultrasonic aspirator. People are afraid to use the ultrasonic. I am not, because I can use it effectively in that area. So this is the cavity of the third, having removed the tumor. Now we'll see it in a video action. So what you have seen in the still picture, you would see it as a video. We are opening the lamina terminalis. This is here the chiasm. That's why people go for a shunt, because they don't know how to do the surgery. They don't want to lose the case, they put a shunt. If this was my daughter, I would not like to see a shunt in her head. You can see the tumor, very apparent. Also, I have to be careful not to damage the optic nerve, the chiasm, and the tract. I keep within the tumor. So during surgery, we send these specimens, frozen section, Dr. Abu Farsakh, and then we send them the permanent. Without putting the thermal on it so that it is not distorted, we send it as it is. So this is the lesion. Ultrasonic aspirator produces ultrasonic waves that will destroy the tumor. So this is the tumor, as you can see here. This is the only chance for this patient to give her the proper treatment. You cannot operate again. This is the only chance of getting good surgical excision and good histological diagnosis without damaging her. Ultrasonic aspirator again. The ultrasonic aspirator, if you put it on the optic chiasm, it will suck it. It will destroy it. So it is your hand which controls where to put it. Again, you can see the blood vessels. And this is part of the tumor going into the pituitary gland. We don't want to damage it. This is the carotid, middle cerebral, anterior cerebral, and this is the nerve tract A1 on the other side. This is the third nerve, oculomotor nerve, going to the roof of the cavern of sinus. Okay, Dr. Farsakh, would you please come over?
My name is Dr. Hussam Abu Fatsah. I'm a pathologist. This is really one of the critical cases that we feel because of the material was few, but and also it had some red herrings. This is most of the material that you can see. You can see a tissue like this. First glance, when you see something like this, it looks like a bone piece. I actually asked Ibrahim if he went through the bone or not, because it mimics bone very much, but it does not resemble it 100%, but it really mimics bone. But when you go to higher power, you can see it's not lined by any osteoblast, and there are some cells inside it, and this is not the way that bones looks like. But there is so much vascular capillaries filled with blood vessels. And you can see how much vascularity of this tumor or this lesion has it. Different better. And this is some glial tissue in here. This is what looks like bone in the low power. Looks like bone in the low power, but then you see that there's no osteoblast rimming the bone, and there's vacuoles. So these vacuoles, it looks like there is some specific fluid that is entrapped in the lesion. And if you remember, when Dr. Ibrahim was taking the lesion out, it looks like somehow mucoid, gelatinous. It also comes in a differential when you see something like this. It's colloid cyst. Of course, the pathologist has to work everything out. Every piece of information in the slide is very important, and we collect it together at the end to get the right diagnosis. This is more of the before they form this osteoid, or what looks like osteoid, inspissated material in aggregates, and probably they collect together to form the large osteoid. But then you look here, this is the glial tissue in here, and it has some myxoid appearance, some cells, inflammatory cells, or some cells infiltrating in between the glial tissue. And there were not really much of this, but this is the meat, or where is the meat is usually in these areas, and the diagnosis should lie with these. You can see here how much of the blood vessels is there, and some fibrin, including some of the small capillaries in the lesion. We go back to the glial area, and you can see the inflammatory or the cells infiltrating the glial area. And it is of very importance to determine what type of these inflammatory cells or infiltrating cells. Are these glial cells? Are these histiocytes? Are these lymphocytes? Because the diagnosis will depend very much on these definitive appreciation of these inflammatory cells. You can see some of these cells, if you look at them carefully in higher power, they are eccentric and they have eosinophilic cytoplasm. This is again another cell, which is nucleus is eccentric, bean shape or kidney shape, and it's eosinophilic cytoplasm. The same thing in here. These cells, when you see them, and sometimes we see some eosinophils. When you see some cells like this, they look like Langerhans cells. This is typical microscopic description of Langerhans cells. So that's what make me alert to do the immune staining, that is to definitely identify these cells. And you can see them when you look at them, and somebody brought to you that these cells look like Langerhans cells. You say, yeah, it looks like Langerhans, so let's do the proper stains for them, because this will make the diagnosis in these cases. See, this is an eosinophil, for example. There are few, but every piece of confirmation for the pathologist is really very important. It's like a math question that you really collect all the answers and to reach the right diagnosis. This looks like a Langerhans cell to the eosinophilic cytoplasm. And some cells, they don't have much. Probably these are lymphocytes in my interpretation in this area, and some of them probably histocytes. But you see some also globules here. And these probably the ones that they connected together to form the larger one that looks like the bone tissue. This is more. I took many pictures of this because this is really very interesting and very tricky case. This is the glial area, and there are very few of these, as I said, and you can see the Langerhans cell is more. When somebody points out that these are probably Langerhans, they said, yeah, they look like Langerhans. So let's pay more attention to them. You see more of them in here and here and here. But then it will be only a matter of opinion. In pathology, we don't take any more just matter of opinion. We start with a matter of opinion, but then you have to compare with what you understand. If you want to be 100% sure, you cannot get the tumors usually without doing immune staining, because it differs very much between any diagnosis from the other if you miss the immune staining. Here again, here the what looks like Langerhans cells. Some of them connected are together here, and the same thing in here. Some myxoid areas.
Dr. Hassan, in your experienced eyes, are these nuclei typical of this? Are they cleaved enough in your eyes to be?
They are bean shaped and they are good enough for. See, these are, for example, these are looks like histocyte, vacuolated cytoplasm, and they have bean shaped. Some eosinophilic cytoplasm, some of the cells like this, There are many of them. When you look at them, there are many of them. These also. I took pictures of almost of all the areas. I think, as I said, there were not much glial tissue. This is, for example, one higher there to power. You see the area. See how the cells are usually bean shaped, and this is eosinophilic cytoplasm. Some of them vacuolated cytoplasm, because some of them will be histocytes.
This is regular H&E, right?
Yeah. So what I did, we do stains. We do stains always. This is JFAB, and you can see the glial tissue is JFAB positive, and you expect it to be JFAB positive. Then we have two main stains that are important for Langerhans cells is CD1A, and you can see them here, strongly positive. These are CD1A positive cells, very strongly positive. So we know what we are dealing with Langerhans. Then we did CD68 stains, histocytes and stains, and Langerhans considered part of histocytes. And so most of the cells that you saw infiltrating the glial tissue are really CD68 positive, which means they're histocytes. Some of the histocytes would be Langerhans cells, but once you see so many histocytes, usually this makes the diagnosis of malignancy very unlikely in the brain. When you see so many histocytes in any tumor, makes the diagnosis of malignancy unlikely. That does not mean rule it out completely, but make it unlikely. You have to think twice before making diagnosis of malignancy. If you see histocyte, that's why I like to do CD68, because really sometimes in inflammatory conditions versus low-grade gliomas, it's helpful to see which is which.
Unless, of course, it's the histiocytic neoplasm, histiocytic malignancy.
Yeah, which has other markers. This looks like common antigen LCA, and you can see scattered lymphocyte cells. Some histocytes may also stand with LCA, but you can see scattered lymphocytes. So we know that these have. Then we have S100, I think. See, this is also S100. S100 stains Langerhans cells. It's nuclear and cytoplasmic staining, and it is very strong. So now I have this very tiny tissue. I have CD68 positive cells, CD1A Langerhans staining cells, S100 positive cells. That makes me comfortable enough to call this is Langerhans histocytosis. But I want to just point out to that PS stain. This is the material that looks like osteoid it says has a weak staining for venous, which is not usual for bone, because literally, and it took me some hours to sort them out, whether this is really bone or to me, what it's really happening is that the tumor, because it's slowly growing, some of the associated CSF fluid get entrapped, and the fluid, when it get entrapped, and insufficiated, can get really in clusters, and we saw some stages of it, and it may mimic bone. The other differential was to me when I saw something like this is to rule out colloid cyst, and I usually use cytokeratin 19 because we had publication. Cytokeratin 19 is very good to see epithelial cells, even if you don't see them by H&E, and it was completely negative. Cytokeratin 19 is very good in all cysts of the Ibrahim, and it was completely negative in this case. So by this, all the criteria that I had, I comfortably can call this lymphocytic lesion consistent with Langerhans histiocytosis. In the cross section, actually, we called it lymphocytic lesion. I said there's no tumor in this, and we confirmed it by very good. Thank you.
So the diagnosis is Langerhans histiocytosis. This is pre-op, and this is post-op. Pre-op and post-op. Pre-op and post-op. And this is the girl being preserved completely. Her right-sided weakness improved. Her eye movements were okay, no facial weakness, no pituitary dysfunction at all. This is follow-up. So what is Langerhans histiocytosis? Let's go back to the rules. The reticuloendothelial system made of reticular cells and endothelial cells. And the macrophages are either macrophages, micro or macro, and the histocytes are considered to be macrocytes. It all goes back to this man, Paul Langerhans. He's a German pathologist and scientist. That's him young and old with his wife. And this is his thesis where he described these cells. That is his thesis back in 1869. He found a cell in the skin, and he looked at it and he called it Langerhans cell. And everywhere he see it, he will call it Langerhans. So he found some cells in the pancreas, and he called it islets of Langerhans, which we all knew when we were in the medical school, islets of Langerhans, producing the insulin and so on. So Langerhans cell is what? It is a dendritic cell, as you have seen, present everywhere in the body, epidermis, external genitalia, respiratory, and it is everywhere in your body. And what triggers this Langerhans cell to go into crazy growth is some triggering factors, virus infection, other malignancies, and so on. And this disease is a chronic disease. There is a spontaneous resolution, reactivation, progressive course, dissemination course, and sometimes it is fatal. Different names for this kind of pathology, starting with eosinophilic granuloma and Schiller-Christian disease, Litereur-Sbeih disease, and histiocytosis X. And we settled with this. Now, no one uses these. It's obsolete. So never say Schiller-Christian disease does not exist. So now we settle for Langerhans cell histiocytosis. Let's see the evolution. Mr. Hand and Mr. Schiller, Mr. Christian, they coined this Hand-Christian-Schiller disease a long time ago. So this is Hand-Schiller-Christian disease. It's a systemic disease. It's a fatal disease. And this is publication about Hand-Christian-Schiller disease in children and in adults. Then came Sbeih, Litereur and Sbeih. they describe this systemic disease going everywhere in the body, usually fatal condition. And then this man from the States, he said, well, they are different names, so let's group them and call them histocytosis X. X meaning I don't know what it is. X is the unknown. So histocytosis X because nobody knew what they are dealing with. And then this man, Nizilov from France, he called them Langerhans cell histocytosis. So we're now in this stage, no more hand, crest, and shoulder, no more literacy, no more anything. And then there is a society in the world called Histocyte Society. They said, well, Langerhans cells are histocytes as a class 1 histocytosis. And they classify them into 3 classes, class 1, class 2, class 3. And this is class 1 is the Langerhans cell histocytosis. And then you go into a complex terminology. And then further classification, Langerhans cell histocytosis was revised into a dendritic cell related disease. Non-Langerhans cell histocytosis revised into macrophage related histocytosis. And then class 2A and 2B, again, different terminology. Class 2B, Rosai-Dorfman's disease. Class 3, the malignant histocytosis was called malignant histocytosis as thing. So you can see that Langerhans cell histocytosis is an enigmatic disease with so many faces, with so many unanswered questions. Are we dealing with a tumor or are we dealing with immune dysregulation? Now it has been settled, this is a tumor. So Langerhans cell histocytosis is a clonal proliferation of bone marrow derived dendritic cells plus T lymphocytes and eosinophils and so on. If you look, you can see those straight things are for the Langerhans cells, and those, the curves, are for the histocyte and eosinophilic cells. So the disease is probably a clonal neoplastic disorder. It is a tumor. And there is a recent debate now whether this is a kind of myeloid neoplasia, and they are been using the oncogenic BRAF V600E mutation, and they found that those who have this, they are better, they have a more aggressive course. And some papers on the BRAF mutation, the V600E, this is the recent. And this is the characteristic of the cell. This is the cell itself, Langerhans cell, and it has this, like a zipper. So this body and the zipper here, it looks like a racket of tennis. And this is bareback bodies, very pathognomonic of Langerhans cell. How often is that happening? In children, it is more, 8 to 10 cases per million per year, adults less. It could be localized, it could be systemic, one system or multiple systems. This is the multiple system. Any organ in your body can be affected. The children peak is 1 to 3 years, adults peak 30 to 40. Males are more affected, unfortunately. And the poor prognosis is seen with mortality of 20% in young children in multiple organs and poor initial response to therapy. Size. This is just a sketch showing that it can affect the skull, femur, pelvis, vertebrae, ribs. Never ever affect the hands and feet. Very characteristic of Langerhans. So it can affect the skin, common, 55%. Any bone in your body, any lung, any organ in your body. So this the skin. It is very common pediatric disorder. They're coming with these lesions of the skin. احنا بنسميها ايش بنسميها من pumpkin dermatitis. This is not pumpkin dermatitis, this is Langerhans cell histocytosis. But because we just think of one thing, we just are getting to be prisoner of that one thing we think of. Congenital Langerhans in this baby. Look at this scaly dermatitis in this child. and the scalp. And the lesions in the bone could be lytic, could be osteoblastic. This is one case of mine, a 5-year-old male patient coming to me with this lesion in his skull, which I removed and proved to be histiocytosis, and he pulled through with chemotherapy. Another girl from Iraq, 11-year-old with this lesion affecting her orbit. We removed it, and again she received chemotherapy and she pulled it through. So it can affect the orbit, can affect the bone, temporal bone. It can affect the ENT system, otitis media with diffusion. Very characteristic, external otitis media, external otitis and otitis media. So not every otitis is simple. And it can affect the petrous bone, can affect the clivus, clivus and sphenoid, can affect the vertebrae. Look at the vertebra here, totally destroyed. Bone is destroyed. So also they have this predilection toward the hypothalamus pituitary axis and getting with all kind of hypothalamic dysfunction, as we have seen in this girl. So many times radiologists will come across this enlarged stroke, and people don't think much of it. This enlarged stroke could be Langerhans histiocytosis, producing so many anterior and posterior pituitary dysfunction, as in our case. Publications about cases in the hypothalamus, pituitary stroke involvement, as you can see. Infundibulum, pituitary itself being affected, and also again the hypothalamic pituitary axis. Can affect the basal ganglia, can affect the cerebellopontine angle, so it can be anywhere. But if you don't think about it, you will misdiagnose it. And I'm sorry to say it, but the number of differential diagnoses in the minds of our radiologists is so little that they don't mention all these differential diagnoses, and they should. Here, this is Langerhans histiocytosis looking like glioblastoma multiforme. Here, it is affecting the pineal gland. Here, it's affecting the parathyroid glands, the thymus, the lungs, the liver. So if you have a patient and you suspect Langerhans histiocytosis, you must do systemic survey to know whether you are dealing with an isolated disease or multiple system. So multimodal imaging, whole body MRI, PET CT scan, bone scintigraphy, and so on. So plain X-ray is not enough, MRI is not enough. You can do CEA as a marker, and you can use the positron imaging tomography to see the lesion, as in here. You can see it here, you can see it here. So you have to exhaust your investigations. Here again, a PET scan for this lesion, it is quite obvious. And then you can do bone marrow to see if there is infiltration by Langerhans cells. Treatment, surgical resection, either gross total or subtotal according to where you are. In this case, because we are in the third ventricle on the hypothalamus, we went for a subtotal resection. Now we will send her for a low dose radiation or a combination chemotherapy. Dr. Ala is our oncologist, hematologist. Could you tell us about the chemotherapy for these cases?
Thank you.
Histiocytic disorders are extremely interesting part of pathology. And the most recent WHO reiteration, the number of histiocytic neoplasms exceeded 100, and each one of them is different. And the most common one of these is
Langerhans cell histiocytosis. Now, this is the most common, but it's not one disease. And as you've seen from the elegant presentation of Dr. Ibrahim, the major question is, it's a monofocal or multifocal. And if it's monofocal, does it affect the brain or the most common side, the bone? And anything exoskeletal, that's an issue of dissemination, and it's acted as multifocal disease, as would be disease that is monofocal in the bone that would progress through radiotherapy. One thing it's important to establish the diagnosis, and by the establishing diagnosis is not an easy thing. And the differential diagnosis that, again, Dr. Ibrahim has elegantly demonstrated is vast. And if you don't have the tissue biopsy and tissue diagnosis, you'll miss those, and you'll run into the trap of treating something by radiological appearance. And there's so many things that this could have masqueraded as. The mainstay when in the bone depends upon where the bone involvement is, and when it is in the skull or skull base, then you have all the issues of what is this abutting and what is this involving. In the lung, the soft tissue is extensive, so you have more room to maneuver. But when you have brain involvement as this, you would treat really more aggressively. The mainstay is the surgical resection that Professor Sbeih has elegantly demonstrated. These lesions or diseases are radiosensitive, and they can respond to low dose radiotherapy and to definitive radiotherapy. Now, nowadays it is routinely to perform BRAF testing, and Dr. Sbeih has alluded to this. And by immunohistochemistry, you can test for the BRAF V600 mutation, and its presence by immunohistochemistry is not enough. If the immunohistochemical stain is very positive, highly positive, that's highly suggestive of BRAF V600 mutation. But that's something that is more frequently ascertained either by PCR methodology or more commonly by whole genomic sequencing. And the difference between the first two cases Professor Sbeih has alluded to, one of them was 20 years ago, and the recent one that was this year, is the access to whole genome sequencing has become so readily available at much more affordable prices that it is actually easier to do whole genome sequencing on the specimen obtained, as opposed to do the serial immunohistochemical stains, RT-PCR stains, and PCR stains that would have been done otherwise. That would have been, and by the time you would get the results, you can actually sequence the whole genome, because it's not only BRAF V600 mutation that we look for that has therapeutic implications. These tumors tend also to have other mutations in the PI3 kinase pathway and the MET pathway, etc. And all of these have therapeutic implications. So in the BRAF V600 positive lesions, not only by immunohistochemistry, by PCR or by whole genome sequencing, these patients can receive vemurafenib, which is a medication that is used commonly in the other malignancy that is frequently associated with BRAF V600, namely a malignant melanoma, particularly melanomas that affect the brain. And because vemurafenib can penetrate the blood-brain barrier. So vemurafenib has surfaced as a therapeutic modality that can readily be accessed. And again, stressing that it can readily penetrate the blood-brain barrier, making it quite attractive in BRAF V600 mutations in these patients. MET mutations can be positive in these patients, and they would also be available for cobimetinib and the like that are MET directed. These are the new approaches gene-wise. Now, the classic chemotherapeutic approaches that we frequently use in LCH, methotrexate alone, Aracy alone, methotrexate with aracy-cytarabine together. And these are regimens frequently used in primary CNS lymphomas, and they readily penetrate the blood-brain barrier. The question is whether to use methotrexate at the usual doses we use in primary CNS lymphoma, which is anything in excess of 3.5 grams per meter squared. The doses of Aracy that is used are usually in excess of 2 grams per meter squared, or the single or in combination. Cladribine has also shown to be an active regimen, and it's usually used as a first-line regimen in these cases. I have to emphasize that the frequency of PI3 kinase mutations and BRAF mutations has really changed the landscape. And we will never get prospective trials of comparing one modality to others just because of the variety of these diagnoses. So it really depends upon the scenario you're dealing with. I also have to stress that steroids are active generally in these cases. And other medications that can be used, vinblastine alone or with etoposide in this context. Stressing the importance of genome sequencing when they're diagnosed in the beginning. Now, vimvrafenib is the most commonly used one, but this is not the only BRAF inhibitor. There are currently 3 BRAF inhibitors in the market, and most of these are used in malignant myeloma. The same would apply to cobimetinib. There's not only one MET inhibitor in the market. There are currently 3 MET inhibitors that are used in context with the BRAF inhibition. Because sometimes when you block BRAF alone, you'll get hyper signaling through the MET pathway with paradoxical progression of the disease. Vinblastine usually is given in the context with steroids. Again, there are no head-to-head comparison between any of these agents. And this is only stressing LCH with cranial involvement or with exoskeletal involvement. When it is restricted to the skeletal bone, you can resort to either low-dose radiation or high-dose radiation, but you can also utilize agents like zoledronic acid and the like, because they're active in that context. But this would not really apply to anything that is exoskeletal. And thank you for the opportunity of discussing this interesting case.
So as you have seen that chemotherapy becomes the standard of treatment for these cases, and in the single system involvement, it has a good prognosis. This using vinblastine and showing the lesion just by using vinblastine disappearing. Vinblastine chemotherapy over 12 months, again, the lesion is disappearing. So chemotherapy is the mainstay treatment. Other treatments, antimetabolites.
CDA is cladribine.
Sorry?
CDA is cladribine.
Yeah. I finished, and this is just a picture from the Dead Sea. When you float on the surface of the water, and this is River Jordan and the site of baptism there. Pope visiting us some time ago, Mount Nebo. With this, I finish, and we'll open the question for our audience abroad, and then we'll take questions from yourself. John, are you there?
Yes.
Okay, and you have any questions?
Okay, the panel's open. Any questions or comments from the panelists? Don't be shy. Well, they're quiet today, Ibrahim, but I tell you, that was a quality webcast with so many disciplines involved. I had no idea you were going to do this, but I'd like to thank Dr. Juma, Dr. Nafel, Dr. Hassan Abu, and the last gentleman, I didn't catch his name. I'd like to thank all of them for taking the time to participate in this very well-rounded, surprising webcast.
Thank you, John. Thank you very much indeed. I will pass your congratulations to them. Floor is open for discussion, Mohammed.
I want to ask, what's the next step for our particular patients?
Chemotherapy.
Chemotherapy.
Yes.
Which type?
It's not my decision. It's for the oncologist to decide.
Next question. What is the predictor that this patient can respond to chemotherapy or radiotherapy or steroids or anything? Is there any predictor?
No, but single system is much better than multi-system. So better prognosis in single system, worse prognosis in multiple system.
I mean, brain lesion like this, what is the predictor to go for this chemotherapy or radiotherapy?
It's not my field. Dr. Ala should answer this. He's not that. We'll ask Ala.
Second thing, I want to start.
Ala,
RAF mutation 600, it is very common in thyroid cancer.
True.
Is there any relationship between this histiocytosis and the thyroid cancer?
no.
And is the therapy here the same?
The extracranial and the intracranial histology is the same, and the treatment is the same. That's in multiple system, an extraskeletal system.
I know for histiocytosis.
Ala, would like to ask you. There's a question from Hamid Bima wants to ask you.
There is a very common BRAF mutation in thyroid cancer. And there is a targeted therapy for patients with the BRAF mutation. Can you use these targeted therapy for histiocytosis with positive BRAF mutation?
Yes, this is what I've been discussing. BRAF V600 mutation, this is actually the same mutation. BRAF V600 mutation is the same mutation you see in thyroid cancer. It's the same mutation that we see in malignant melanoma. And it's actually the exact same mutation that we see in colon cancer. And in some instances, lung cancer, non-small cell lung cancer. So now actually one of the interesting changes that in this era of genomic directed and precision directed therapy, where the therapies are more site agnostic and they're more moved by the mutation found. Now, the implications of BRAF V600 mutation malignant melanoma, of course, is very different than the implications when finding them in colon cancer. Though the three BRAF directed therapies used are actually the same ones used, but the three are not, they don't have the same FDA approval among the different etiologies. So not all BRAF inhibitors are approved for all BRAF V600 mutations. But vemurafenib, despite the fact that it is not actually technically FDA approved for all CH, because no company will apply for approval for such a rare indication. The paperwork they have to go through will never materialize. But vemurafenib is used in LCH and is used for papillary for thyroid cancer that is BRAF positive, and is used in a malignant melanoma that is V600, BRAF V600 positive. So it is actually the exact same mutation, but the context of the mutation is different among different cancers. So vemurafenib as a single agent is not approved for BRAF V600 colon cancer, for example, despite the fact that it is the same mutation, because the context of the mutation itself is different. But that's not the only targeted therapy that is used. Cobimetinib, that is also used in malignant melanomas, is used in lung cancer, and other PI3 kinase directed therapy. But just because of time restraints, NTRK mutations do happen in Langerhans, and they are readily targeted with entrectinib and the like, and that can be used. ROS mutations can happen. CSFR1 mutations can happen, and therefore the inclination now is actually to do whole genome sequencing, because you're not only looking for BRAF-V600, despite that this is the most common.
Another question. I was a witness of one case many years ago, maybe 30, which is a classical hand-shoulder crystal disease. It was manifested by osteolytic lesions in the scalp or brain, and the hypothalamus and the cerebellum. And at that time, I treated with zoledric acid plus therapy for the eye, but there was no definite. It was neurosurgery, like thickening of stalk, but there was no definite tumor.
Absolutely. When there is thickening of the stalk, you do all the general surveys. And if you don't have an answer, you will have to go for a biopsy. So Langerhans cell histocytosis should be always thought of if you have thickening of the stalk.
When you showed a couple of reports at the end where the patients with intracranial treated primarily by chemotherapy. So I'm curious, how did they come to the conclusion that this is the disease, start with this chemotherapy? Clearly not that the imaging is not pathognomonic.
Absolutely.
So is it a trial and error? I'm just curious if you read those reports.
It's all based on histopathology. So
But clearly there wasn't a histopathology in those cases.
no, there is. There is. All the cases I showed in the papers, they have histological data. Any questions, please? Go ahead, Hazam, radiologist.
Which I totally agree with you that.
Haitham Hazam is a radiologist, and the one sitting beside him is Dr. Saleh Nasras, Jordanian, who was working in Iran, in Ahwaz, yes. He's a professor there, and he's the pride of Jordan in Iran.
I agree with you, totally I agree with you that most likely diagnosis and differential diagnosis is very, very important issue in the report of radiologists or in general. My question is, what is the rate of recurrence of CNS granuloma, and in cranial wall granuloma, do we do surgery? There is the most option surgery, decortication, and radiotherapy, or what is the choice of?
I had two cases where I did not go for surgery. I sent them for our radiologist, and we have taken needle biopsy. I needle biopsy gave us the clue we started. But if you are in doubt that you cannot get enough histology from the specimen, then you can have all. Any other questions, please? For Saleh Nasras? You can, but I don't like it. I like the laminated, it's straightforward. Going through the corpus callosum, take it to the third lateral ventricle, and then go through prominent. It's a lot of hassle. So I love and I established this approach of laminated. Sure.
And the second thing that my point is room, the part which they do. When this thing is in the skull, I think that surgery will be accurate. And there's no
Right. Definitely, if you do radical excision, then you may observe before you do treatment. There are so many cases in literature saying that there is major recurrences after radicals. So maybe it's wise to do that.
And when it's bone alone, in the skull, when it's bone alone, your options are numerous.
So bone directed therapies, bisphosphonates, intravenously, low-dose radiotherapy. A lot of the chemotherapy options that I've discussed were actually geared to when you have a single site in brain parenchyma, where you really need the blood-brain barrier penetration to be more aggressive. But when you have only a skull lesion, your options are much more limited, depending on the size of the skull.
Any more questions before we close with our colleagues in States? Okay, John, thank you very much indeed, and I pass your congratulations to Dr. Muhammad Jum'a, to Dr. Ala Abdasi, Dr. Rad Nokhel, and to all those who participated today. Thank you very much indeed.
Okay, very good. Like I said, Abraham, that was a surprise. And next time, I imagine you're going to have another multidisciplinary presentation, correct? Next week, Abraham, or 2 weeks, you're going to have a multidisciplinary.
Yes, in 2 weeks' time, we will present a case of choroid plexus papilloma in the fourth ventricle, which is a rare case. Have many cases, and the last case was extremely interesting. So in 2 weeks' time, we have the same meeting about choroid plexus papilloma.
Yeah, well, not many people do it, so we'll promote it that way, multidisciplinary.
Sure,
So
sure.
thanks everyone for coming, and thanks for your presentations.
Thank you, John. Thank you.